Hello, class, and welcome to the lecture. This is Dr. Lee, and you're listening to part 4 in a series where we're talking about the pharmacology and toxicity of antineoplastics. And within this module, we're going to be going over the immunotherapy agents. Specifically, we're going to focus our discussion on checkpoint inhibition. And this is a major breakthrough in cancer over the last few years. And prior to about 2010 or 2011, we did not really have many viable immunotherapy options in the treatment of cancer. So the theory here is that tumor cells are theoretically supposed to be foreign agents, foreign bodies that are not recognized as self. And so there must be something with the wrong with the immune system in terms of not being able to recognize these tumor cells and have your body mount an immune response to this. So back in the dark ages, we tried many different types of agents, such as giving interferons and cytokines to try to boost the immune system and the immune response to tumors. That turned out to be incredibly toxic with very few benefits in terms of efficacy. And therefore, you can see that I've taken those drugs just completely off the list of the main categories of immunotherapies. Perhaps some guidelines will still recommend interferons and interleukins in some of these rarer and obscure tumor types. Not too concerned about that. Really what I want to talk about is this whole breakthrough within checkpoint inhibition. But there are other categories of immunotherapy, such as you've heard about cancer vaccines, and we would really call those autologous cellular immunotherapies. So basically removing patients' T cells and giving it back to them, priming them against a tumor antigen. Or we have these genetically modified oncolytic viral therapies, so basically modifying a herpes virus to have a gene that would infect tumor cells and cause lysis within those cells in which it was injected. So those would be those cancer vaccines that you might hear about. We also have this new class of medications called chimeric antigen receptor T cells, and we'll go into those specifically as we talk about the different hematologic malignancies that we're using them in right now. But also we have things like bispecific engagers, and again, we'll go into those discussions as within the specific disease states itself. Now, with checkpoint inhibition, what we want to talk about is what that actually means in the grand scheme of things. And so this quote comes from this article here that I've listed and referenced on this handout, in that immune checkpoints refer to a plethora of immune pathways, of inhibitory pathways hardwired into the immune system. They're crucial for maintaining self-tolerance and modulating the duration and amplitude of physiological immune responses in peripheral tissues in order to minimize collateral tissue damage. And wow, that's a powerful statement and a lot of things here. So let me just highlight some of the main points here. So number one is this plethora, which means that there is more than one immune checkpoint. And I've listed from this article here some of the different checkpoints that they're talking about. So what we're going to be talking about specifically is this PDL1 checkpoint, but there are many checkpoints that are out there. So what are these checkpoints? They're inhibitory pathways, and they're hardwired into the immune system. So they inhibit the immune system. These are checkpoints that inhibit the immune system. And why would you want to inhibit the immune system? Well, that's crucial for maintaining self-tolerance. Okay, so making sure that you do not recognize your own tissue as self. And why would you want to maintain self-tolerance? And when would those situations occur? Well, that's when you're modulating the duration and amplitude of a physiological immune response. So say, you have an infection, or you even have something like a cut where you need to mount an immune response. And these checkpoints allow you to modulate the duration and amplitude. So again, how long the immune response lasts for and the severity of that immune response due to perhaps that injury or that infection. And that's all to minimize collateral damage. So if we didn't have these checkpoints and basically let our immune system run wild during this maybe perhaps relatively minor situation of perhaps an injury or an infection, then we have way too much collateral tissue damage, and it would actually kill us in the long run. So we should be grateful for these immune checkpoints to keep our immune system in check so that we don't have this case of severe collateral tissue damage. So right now, we have two checkpoints that we take advantage of that have therapeutic relevance. And the first is this checkpoint called CTLA4. Now, CTLA4 downregulates T cell function in general, and it's essential for normal immunologic homeostasis. So this is just T cell regulation in general and T cell function in general. How active are your T cells? So this again would be that modulating factor for that more of that amplitude and I guess duration as well of that physiological immune response. It's akin to shutting off the circuit breaker in your house if you're trying to turn off the lights in your house. It's a very, very powerful checkpoint. And if you inhibit this checkpoint, then what you're doing is you are essentially increasing T cell function overall and mounting a large immune response. And so the next checkpoint that we have to talk about is this programmed cell death protein, or PD-1. And with PD-1, the role here is to limit autoimmune immunity during an inflammatory response via dampening T cells in peripheral tissue. So it doesn't affect T cells overall systemically, but within specifically peripheral tissues. This is the major immune mechanism of resistance in tumors. So what this means is that if you have a tissue over here, so we have some sort of normal tissue, and you have this inflammation that requires an immune response, and over time the checkpoints will kind of develop and say, all right, well, I'm expressing this PD-L1 checkpoint, and this antigen presenting or this antigen experienced T cell comes by, and they have a PD-1 receptor on the T cell, and they meet up with the PD-L1 receptor on the tissue, and it recognizes that as self, and so there's a self-tolerance mechanism that happens there, and the immune response is dampened because it recognizes this tissue as self. Now, that's a good thing if we're talking about minimizing collateral damage to our normal tissues, but if we cross that out and do tumor, then all of a sudden we have a problem, because now you want the T cell to mount an immune response to it, but the tumor cell is now hiding through the expression of PD-L1. And this does happen in certain tumor cells, and we can actually measure the amount of PD-L1 within certain tumor cells. So now what we want to do is actually inhibit PD-1 or PD-L1, and we can do that through these monoclonal antibodies, pembrolizumab, nivolumab, or inhibit PD-L1. Remember, PD-1 is on the T cell itself, and PD-L1 is within the tissues, and so we have monoclonal antibodies that would inhibit both of those sides. Again, by inhibiting that, it allows the T cell to not recognize and not have the self-tolerance to the tumor, and again, mount an immune response to that. So the point here is that you're taking advantage of these checkpoints and inhibiting these checkpoints so that you can mount a better immune response to the tumors. And because of that, we're going to have the general toxicities related to immune-mediated toxicities, so things like colitis, rash, pneumonitis, hepatitis, and endocrinopathies. Now, for your CTLA4 inhibitors, that's going to be very, very severe, and a lot of patients will have lots of problems with immune-mediated toxicities. With PD-1 or PD-L1 inhibitors, the immune toxicities are much, much lower in terms of the rates are much, much lower, but the severity is still there. So the bottom line there is that fewer people will get these toxicities, but If they do, they can turn into a very severe situation pretty rapidly. And what you're going to have to do is monitor patients and make sure that they go on the correct protocol to treat those immune-mediated toxicities. So that's it with this section for immunotherapies, specifically focusing on checkpoint inhibition. If you like this video, go ahead and give it a like. Provide me with some comments in the comments below about what you liked or what wasn't so clear about this lecture here. If you have any other questions, feel free to let me know. You know where to reach me. Subscribe to the channel if you liked it, and I will see you in class.